and live workshop. Today we do have a case of gastric mucosal lesion in 72 years old female, incidentally discovered due to upper GIT discomfort. And the lesion, as we see now, it's lying in the gastric antrum close to the prepyloric region. And Dr. Hiwa is marking the lesion from the circumferential side to avoid any skirt lesion extended beyond that.
Needle injection.
First of all, we did the characterization and examination of the mucosa of the lesion, and it seems there is no highly suspicious area, but the patient had an anxious feeling from this could be tumor, especially that she had before an EUS examination to assess this lesion. So the point is we are trying to illustrate the strategy of doing ESD and superficial resection for this lesion in the antrum, especially it's lying close to the prepyloric region. First of all, in our strategy, we will inject submucosal methylene blue mixed with hyaluronic acid at the distal part of the lesion close to the pyloric area.
Needle in.
And this will make the lesion elevated and get closer to the scope into the gastric side. Of course, this will facilitate to make an incision for our endpoints at the pyloric margin. And as we see, the point of injection is very, very crucial. We are trying to inject close to the pyloric opening. Few milliliters of hyaluronic acid as it's seen. Now, as we see that the edge of the prepyloric side is getting inside the stomach.
So thank you very much, my brother, Dr. Amr Alfouly. Special thank for Dr. Abed, Dr. Nawaf, and other colleagues for your kind invitation. This is a great honor for me to demonstrate gastric ESD with my mentor and my brother, Dr. Amr Alfouly. For gastric ESD, usually we have to do there's absolute indication, well-differentiated gastric adenocarcinoma or polydifferentiated non-ulcerated gastric adenocarcinoma. Usually we take biopsy because for biopsy confirmed lesion, we do ESD. And as he mentioned, we usually start our ESD as a strategy-based procedure. So any lesion near to the pyloric ring or to the cardia, usually we start by mucosal incision from the pylorus side. And as you saw by my marking, that I escaped marking the pyloric region because it's not necessary. Already the pyloric ring is well demarcated. And usually we start marking 2 to 5 millimeter away from the lesion, and the distance of the marking is about 2 to 5 millimeter. And we do incision 5 millimeter away from the marking area. I use for mucosal incision endocut eye 2 to 2 interval duration and effect, and I use force coagulation for dissection and minor bleeding control. Today I use Olympus scope 1500, which is diagnostic scope but very good scope. The working channel 2.8, which is preferable to use 3.2 working channel. And I use Olympus dual J knife 2 millimeter. Usually for gastric body and antrum I use 2 millimeter, and for cardia or esophagus I use, or duodenal with colonic ESD we use 1.5. So I will start by seeing the marking area. So this is the marking. Needle out, please. So needle out, and I do one sharp cut, and I am sure that the needle inside the mucosa. So I press by the white ceramic tip, and then I go steady, hooking and cutting. Well-controlled procedure, hook, cut. And sometimes if I face difficulty, I ask my assistant to do some injection during the procedure. But today we don't have any resistance, so I go stay this because I don't want to lose my view. So you can see from first incision, we can see a well demarcated submucosal field because I use 2 millimeter knife. For mucosal incision, you can make the knife little bit longer. For example, 1 centimeter or more than 5 millimeter longer. But for other step, it is preferable the knife to be short because during dissection when we are very close to muscle, it is preferable not to be close to the muscle. So you can see I am doing mucosal incision outer border of the marking. Then I go on the same line tangentially, and in short position I make some trimming of cutting muscularis mucosa, because the key of good ESD is good incision and good trimming. So I make the white ceramic tip inside below the mucosal flap because I don't want to burn my mucosal flap, and I do dissecting the muscularis mucosa and remnant of submucosal tissue, and I coagulate by forced coagulation, and I make the muscle to be exposed.
So the trimming is done by the forced coagulation. We
Yes.
are using a dual knife from Olympus, and it's 2 millimeter, which is convenient in the gastric ESD. And this is the end point, as we mentioned, for the ESD for our lesion, close to the prepyloric region. First, we have done the incision and then the trimming, so you have a good gapping and good separation for part of the submucosal side. So what will be our strategy, the next strategy for the rest of the region? You will do circumferential incision.
Most probably I will start by cutting this side, and then I go to the other side, because probably I will face some difficulty while I am cutting this area.
Now this is some part of the mucosa still attached, and we are trying to trim it to separate it from the mucosa to make it. As you see also, the muscularis mucosa is retracting the region in the stomach. When you make the
Needle
incision,
injector.
the muscularis mucosa will retract the lesion away from the edge. So it's getting smaller or shrunken from the central part. And this is, of course, one of the methods of physiological retraction to
Yes.
facilitate going to the submucosal spaces.
And because for the gastric ESD, the gravity will not help us like colonic by changing position. So the best way is to make a strategy-based procedure. Needle out. You see, I am fixing the length of my knife, my needle injector, and I ask my assistant to inject. So inject, and I'm pressing, okay, needle in. I don't change the length of the needle injector. Needle out. Injection, little bit. Okay.
Excuse me,
Needle in.
I didn't hear the question.
Sorry. Needle out.
No biopsy was taken from
Needle
the
out.
lesion. But there was a
Needle in.
if you could make a good characterization with the endoscope, and you have the feeling it is malignant or potentially malignant or benign lesion, as long as it's mucosal lesion, sometimes the biopsy is not mandatory in ESD. And by doing, or the learning curve of doing this characterization and assessment will make you could judge which lesion which will need biopsy or suspected deep invasion, or which which lesion will be superficial and convenient for the ESD.
The only point make biopsy necessary in gastric ESD to differentiate well-differentiated gastric adenocarcinoma and from poorly differentiated gastric adenocarcinoma, because according to the Japanese guideline for gastric poorly differentiated gastric adenocarcinoma, we cannot go for ulcerated lesion, we cannot go for lesion more than 2 centimeters because of the high incidence of lymphovascular invasion. But nowadays, if there is a well-demarcated area and the surface pattern is well seen, it is usually predict for well-differentiated gastric adenocarcinoma. Needle out?
So we could summarize this here that first we need to know the size of the lesion at the stomach. The second thing, if the lesion is ulcerated, yes or no. The third thing, it is poorly differentiated or well-differentiated lesion. from this criteria, we could go for ESD, yes or no, in case of early gastric cancer. But in our case, yes, please.
Why you decide to do ESD rather than EMR and you don't have a biopsy?
I think this is very good question because this patient very anxious and the biopsy for the first time maybe was not conclusive and there was not healing. So for any non-healing depressed ulcerated lesion and even the biopsy not conclusive, we can go for diagnostic ESD. And the lesion, because located in a very difficult area, so the ESD and removing the specimen in one piece may be the best option rather than doing endoscopic mucosal resection. Because ESD in the gastric not so difficult and the gastric antrum very thick and the possibility of the bleeding in this area specifically very, very low. So the chance of getting bleeding is low. So you can see that I make a circumferential incision. Then I will make a trimming by putting the needle, the white ceramic tip below the mucosal flap or even sometime in the normal anatomical area. And then I go for trimming. I do some the separation of the lesion from the surrounding. This is a key of successful ESD procedure. While I am doing trimming, I ask my assistant inject by the knife, please.
Check, please.
Because the graft, yes. And I do some hole in the area, injection.
As you see here,
Okay,
after
needle in.
injection, the lesion is getting elevated. And you could see the submucosa very clearly, and you could dig with the cap
Injection.
beneath the mucosal side.
Injection. Okay, stop.
This is one important technical point.
So the beauty of this scope that you can see the tip of your knife. So once the tip of the knife is visualized, then the procedure will be very, very safe and easy for you. And usually I use endocut eye for most of the dissection, but once I see some blood vessel in the submucosa, I go for forced coagulation. And my cap making a very good traction.
Yes, your cap is your second hand, pushing the lesion to the left, so you are exposing the submucosa nicely, and you are trying to dissect in a parallel manner.
And because the gravity is located at the fundus, so I will try to make the lesion, I come from the pylorus, then I go toward the pylorus, toward the fundus. I want to make the lesion follow the gravity side safely. And because I see some bleeding blood vessel in the submucosa, so I use only coagulation to avoid bleeding from major vessels. Injection. Okay, stop. The plan, I think we explained it initially, that we make most difficult side first, cutting the most difficult side. So here I have some bleeding, and the bleeding is arterial, so I will change to the RDI mode, and I change to spray coagulation 1.5 or 1.2, and I ask my assistant to change the mode to RDI if possible, without bringing further accessory. Okay, can needle in.
As we know that the stomach is very vascular organ, and we are expecting a larger vessel in the submucosa, especially at the prepyloric region and at the cardia, subcardiac region. And here, in this case, we could try to coagulate with the needle tip with either soft coagulation or spray coagulation, depends. If you see the size If not, we could go for coag grasper.
Grasper, usually.
It's very, very crucial and mandatory.
Because I don't want to make, if I see that it is not controlled initially, although it is decreased, so I go for co-grasper.
Coag grasper,
And
please.
I don't want to injure the muscle because this area, the muscle just perpendicular to me.
So sometimes we could make like compression with the cap over the bleeding site as a tamponading until we prepare our instruments like the coag grasper. Regarding the question of Dr. Noor, I'm glad to see you again here, my friend. The strategy here was to some of the important things that we are facing in doing ESD. In ESD, we have to be competent dealing with bleeding and perforations. These are the major two things we have to keep in mind. As you see now, the boiling is sufficient and open, and this is good hemostasis.
Okay.
Excellent. That's very well done. So I think we'll conclude with this. Our live,
Probably we
session
have
was
only few fiber left.
So
Give me the knife.
We'll keep you both live, Amr and Dr. Hiwa.
Okay.
Thanks, Hisham.
For all interested of live, and we can go now for the break time for 1 hour, and then we'll get back with
Okay.
our,
Thank
live
you.
transmission.
Thank you.
Thank
Need
you.
loud? Need loud?
Thank you.
Thank you so much.
Thank you.
Need loud? Okay. Forced coagulation. Okay. Ready?